Assalamu alaikum and good day, everyone. My name is Dr. Mohammed Al-Houqani. I'm Associate Professor at the College of Medicine, UAE University. I'm also a consultant respiratory at the Sleep Disorder Specialized Clinic in Al Ain. I was asked to talk today about obstructive sleep apnea in Down syndrome. During the next 20 minutes, I'll try to cover the definition of obstructive sleep apnea. We'll talk about how to recognize symptoms of obstructive sleep apnea, how to assess patients with Down syndrome for obstructive sleep apnea, how to interpret the result, and manage patients with obstructive sleep apnea and Down syndrome. So to start with is how common is obstructive sleep apnea in patients with Down syndrome. So in children, it's very common. It's almost 30 to 50% of children with Down syndrome would have some obstructive sleep apnea. It could be mild to moderate and maybe a less extent to severe. Adult patients with Down syndrome, almost 90% of them will have obstructive sleep apnea. Now, how does this compare to a general population? A general population, moderate to severe obstructive sleep apnea is between 2 to 4%. A mild would be much more higher, that could reach 25%. Now, when we talk about obstructive sleep apnea, we're talking about the upper airway. So you see on the left side, patients who's sleeping with a normal upper airway. On the middle pictures, you'll see a narrowing of the upper airway, which can lead to snoring. And on the last one, you see a complete cessation of the airflow and obstruction, which we call it obstructive sleep apnea. Now, what are the symptoms of obstructive sleep apnea? Patients overall could have excessive daytime sleepiness, and this is more common in adults, excessive executive dysfunction, impaired attention, decreased memory, mood dysregulation, depressive symptoms, and at night they may have snoring, nocturia, restless sleep, early morning headache, fatigue, reflux disease. They may also present with a high hemoglobin, we call it polycythemia, or hypercapnia and a very high CO2. Sometimes they present with, unfortunately, late with the complications of obstructive sleep apnea, such as coronary artery disease, arrhythmia, heart failure, pulmonary hypertension, and cerebral vascular accidents. So these are the symptoms and sequelae in adults. What about in children? Well, in children, most of the time, patients will present with failure to thrive, snoring, fatigue, restless sleep, reflux, polycythemia, hypercapnia, and most of the time, also the family would complain of poor school performance, inattention, executive dysfunction, decreased memory, and behavior disruption. They could also present with a complication like pulmonary hypertension and heart failure. Now, what are the risk factors among patients with Down syndrome? So I hope this is really clear to all of you. So patients with Down syndrome can present with adenoid hypertrophy, maybe hypotonia, macroglossia, tonsillar hypertrophy, pharyngomalacia, hypotonia, which can lead to obstruction of the airway, laryngomalacia, subglottic stenosis, tracheal stenosis, hypothyroidism, lingular hypertrophy, and mandibular hypoplasia. Now, once we have patients with obstructive sleep apnea, we need to evaluate them for all what we just mentioned in terms of risk factors. Also, we take their neck circumference and BMI, because we know there's a strong association between a high BMI, large neck circumference, and obstructive sleep apnea. We also look at the facial structure. This patient, for example, is clearly having adenoid faces. We look at the oral cavity for high arch palate, a macroglossia, a hypertrophy of the uvula, or tonsillar hypertrophy, and retrogantry. Okay, we also look at the Melampati score, and Melampati score of class 3 and 4 have a higher risk for obstructive sleep apnea. Now, once we have someone with all the risk factors, all the signs and symptoms of obstructive sleep apnea, next is we're talking about how we confirm the diagnosis. So we do evaluation with a full pulse monography, also known as a sleep study attended by sleep technologists, where the patient is hooked in a sleep lab with EEG to check the stages of sleep, EOG, EMG, airflow, snoring channels, a mic oxygen saturation, respiratory effort, cardiac rhythm via ECG, EMG for leg movements, and as well as video monitoring and sometimes transcutaneous CO2 monitoring. A typical sleep recording will look like this, where we monitor the airflow, and if we see a cessation of airflow more than 10 seconds, we call it apnea. And if we see a paradoxical chest movement, then that would most likely reflect an obstructive sleep apnea. Most of the time is followed by oxygen desaturation, bradycardia, and arousal. So few definitions that we should all agree about is what is apnea. It's the absence of airflow of more than 10 seconds. And hypopnea is a reduction in airflow of more than 50% associated with either arousals or oxygen saturation of more than 3%. Then we calculate the number of apnea, hypopnea, and divide it by hours recorded sleep to come up with an index. We call it apnea hypopnea index. Now, this index is really helpful to classify patients whether they're mild, moderate, or severe. So a mild in adults is 5 to 15, moderate 15 to 30, and severe more than 30. However, in pediatrics, mild is 1.5 to 5, moderate 5 to 15, and severe more than 15. This is very important. And also some of the criteria in scoring is different between adult and pediatrics. Okay. Now, this is an example of a sleep record, sleep study, where you see someone who's having an apnea, which is a cessation of airflow. And this one is a reduction of airflow, and we call it hypopnea. Okay. Another example where you see apneas, as well as you see a chest abdomen paradoxical movement and snoring in between with cyclic desaturation, typical for obstructive sleep apnea. Okay, another examples of apnea with cyclic desaturation, snoring in between, and paradoxical respiratory movement. Okay, another feature for obstructive sleep apnea. This is a little bit different, where you see there's apnea followed by crescendo, decrescendo, hyperpnic phase of breathing, more of hyperventilation. We call this central sleep apnea because there's no respiratory effort with the apnea, and this is a chain stop respiratory pattern. We see this in patients with heart failure or stroke. Another sleep recording where you see no chest and abdomen movement with absence of airflow. So we call this central sleep apnea, but it's different from the previous one where you don't see the crescendo, decrescendo pattern of breathing. So this is a central sleep apnea secondary to narcotics. So the physiological consequences of sleep apnea is basically when the patient sleep and start to have the apnea, oxygen goes down, there's a swing in the pleural pressure, more of negative intrathoracic pressure, a sympathetic activation, which lead to arousal, ventilation, reoxygenation, and sleep. And this cycle may occur more than 30 times an hour in patients with severe degree of obstructive sleep apnea. There's also a cognitive impairment with obstructive sleep apnea, where we see a decrease in slow wave sleep, which is the deep stages of sleep, intermittent hypoxia, which would lead to decrease in the IQ of patients, the executive function. Also, they would have attention deficit and disruptive school behavior. Now, why do we really care about obstructive sleep apnea? Because all what we talked about, the physiological consequences of obstructive sleep apnea, can lead to a very bad clinical outcomes, mainly cardiovascular complication like systemic hypertension, atherosclerosis, congestive heart failure, stroke. There's an increased chance of cardiac arrhythmia and increased mortality and sudden death as a result of severe degree of obstructive sleep apnea. Now, moving to management. So how can we manage patients with obstructive sleep apnea? And let's divide the management into non-surgical and surgical. The non-surgical in general, especially for patients who are obese, is weight loss. For patients with mild degree of obstructive sleep apnea, we recommend a nasal steroid or could sometimes leukotriene receptor antagonists such as montelukast. If patient is having hypothyroidism, we should treat it. Now, we'll talk about CPAP, positional therapy, and oral appliances. Surgical treatment are for patients who are moderate to severe and clearly having anatomical factors leading to obstruction of the airways, such as tonsillar hypertrophy, where we would always recommend adenotonsillectomy. So the treatment, the first line treatment in pediatrics and children is adenotonsillectomy. It would be hard to start them on CPAP, and simply because they have a clear, most of them a small airway, and tonsils and adenoid most of the time does contribute to the obstructive sleep apnea. So the first line treatment in pediatrics is adenotonsillectomy. Now, we should always repeat the sleep study after the surgery to see if there's any residual degree of obstructive sleep apnea. In mild cases of obstructive sleep apnea, we could consider nasal steroid and leukotriene receptors antagonists. We could also consider body positioning, sleeping on the side, especially for mild cases with supine-related obstructive sleep apnea. In patients who are obese, we could recommend also weight management. Now, what if adenotonsillectomy failed? Then we should consider CPAP. We bring the patient back to the lab and do a CPAP titration study. There are other surgical management that are optional, especially if CPAP failed, and we'll talk about it. The last treatment, which we try all the time to avoid, is tracheostomy. So this is the pathway of treatment of children with obstructive sleep apnea. So what about adults? Adults is the other way around. We don't start with surgery. We do start with CPAP therapy unless there's a clear tonsillar hypertrophy, where we would recommend adenotonsillectomy if applicable, which may help the patients to utilize their CPAP machine. Also, if the patient is having deviated symptoms, then we do septoplasty. Beside adenotonsillectomy, we do send patients to surgeon to evaluate for any other possible surgical intervention. Now, what other surgical intervention that we could talk about? Now, most of the time, the surgeon will do a drug-induced sleep endoscopy to determine which procedure will be the greatest of benefits, and may consider tongue-based reduction, lingular tonsillectomy. It could also, there's a major surgery that we call it rapid maxillary expansion in selected patients. Now, we need to remember that these are high-risk patients, and therefore, a very important, number one, we need to ensure that we do a very good preoperative evaluation that include assessment of their heart and thyroid and cervical abnormality. And patients should not do these surgical procedure as an outpatient. They should be admitted postoperatively for monitoring, because we know there's a risk of complication. And in severe cases of obstructive sleep apnea or a high-risk patient, we should ensure that we have an ICU monitoring post-operatively. Another very important part here, we know that the surgery, unfortunately, does not have all the time a very good success rate, and therefore very important that we do repeat the sleep study after the surgical intervention. Now, moving to the second choice of treatment, I should say in pediatrics, and the first choice in adult is a CPAP therapy. So CPAP is a continuous positive airway pressure where the patient will have an interface and a positive airway pressure to open up the upper airway. Most of the time, we bring the patients back to the lab to do the titration study. Machines nowadays are really small, and it comes with really comfortable interface. Some of them are nasal that cover the nose, an oronasal that could cover the nose and mouth, and a nasal bronch which can only get into the nasal, the open of the nasal trails. We talked about the CPAP titration study. Now moving in, what if patients fail CPAP and we think that he has a mild to moderate obstructive sleep apnea? We could consider oral appliances. So the idea of oral appliances that we need to pull the lower mandible forward, and with oral appliances, it has to be a custom made. We should not use the over the market oral appliances. We should refer the patient to a good orthodontist who specializes in sleep medicine for a custom made. And even with the oral appliances, we should repeat the sleep study to ensure that there is no residual obstructive sleep apnea. Now, patients with Down syndrome overall, they unfortunately have many medical problems, and including hearing problem, vision problem, but we need to remember that obstructive sleep apnea is almost seen in 50 to 75% of patients with Down syndrome. So very important for every physician seeing patients with Down syndrome is to ask about symptoms of obstructive sleep apnea at least once every 6 months. Symptoms like snoring, frequent night awakening, daytime sleepiness, apnea, behavioral problem. We need to discuss with them also a referral to a sleep study at least once the patient is reaching the age of 4. Now, here are some references that you could read about. I like the article that was published by CHEST on sleep disorder breathing in Down syndrome. Thank you very much, and I'll be happy to answer any questions. Thank you.